Thank you everyone for connecting. This is Dr. Emre Gorgun, Vice Chair, Department of Colorectal Surgery, and live from Cleveland Clinic, February 21st, 2024. Thank you for joining us tonight. This is a very interesting topic, and we will be talking about total neoadjuvant therapy in the management of locally advanced rectal cancers. As we all know, TNT is widely used across the globe, but sometimes maybe overused or underutilized. So we will discuss all these aspects and give you wonderful talks, by our wonderful speakers, as well as we're going to have a great panel and go over some clinical scenarios and make it more practical from understanding standpoint. So I'm excited to share with you that there are 700 healthcare providers registered for today's event from nearly 90 countries. So that's amazing how far we can reach. And we will be welcoming all your questions. We really want this activity program to be as interactive as possible. And please, we ask you and encourage you to use the chat box on the right side of your screen and send in your comments, questions, even during the broadcast. So we will be answering them as we go, as well as we can address them during the panel. Of course, we cannot make this CME event possible without our corporate sponsors, and we like to thank them for their generosity in providing our educational grants for 2023 and 2024. So for this event, we like to thank Cook Medical, Janssen Biotech, Medtronic, and Olympus. And in terms of our speakers tonight, I'm honored to introduce you our three speakers. They will be giving us really interesting topics: Dr. Smita Krishnamurthy, Dr. Josh Somavilla, and Dr. Ariella Canters. And then in the panel, which we will discuss the case scenarios with Dr. Sudha Emernath from Radiation Oncology. Again, Dr. Canters will be joining us for the panel as well as Dr. Krishnamurthy. Dr. Erika Savage, she's our pathologist and expert in this field. Dr. Somavilla, he will be giving one of the talks as well as Dr. Joe Minero, our radiology tumor board and cancer expert in radiology and imaging. So we have a fantastic group of healthcare providers tonight as part of the panel, as well as our speakers. And with that, I will introduce our first speaker of tonight. This is going to be Dr. Smita Krishnamurthy. She's the staff medical oncologist at the Cleveland Clinic and associate professor of medicine. So her topic will be, should TNT be offered to every patient with locally advanced rectal cancer? Smita, thank you very much for presenting tonight.
Oh, thank you so much, Emre, and I'd like to thank you and Dr. Scott Steele for the privilege of presenting today, and thanks to everyone who's joined us. So this is the question we're pondering today, and just want to take a moment to show what I define TNT to be, total neoadjuvant therapy. Think of it, this is for patients with stage 2 and 3 rectal cancer. That's what I'm going to be covering. And we can start with chemoradiation with fluoropyrimidine or short course, and then go on to chemotherapy with fluoropyrimidine and oxaliplatin. So it's all neoadjuvant therapy, and then proceed with surgery or watch and wait. Alternatively, one could start with chemotherapy, and there's data for doublet fluoropyrimidine, oxaliplatin, and also FOLFIRINOX, which we'll touch on, and then proceed with either long course, long course chemoradiation with fluoropyrimidine, and then surgery and watch and wait. So should TNT be offered to every patient with locally advanced rectal cancer? I think yes, we should offer and discuss, but actually recommend? No, not for everyone. So let's get into this. So what I'm going to talk about briefly is immunotherapy for that subset of patients with deficient mismatch repair cancer. Then we'll look at trials of TNT, and then also look at the option of neoadjuvant chemotherapy without radiation. So to begin with, I think everybody has heard of this study of neoadjuvant dostarlimab for patients with MSI high or deficient mismatch repair rectal cancer, which was published simultaneously in the New England Journal and the New York Times back in June of 2022. This is led by Andrea Sursik at Memorial, and is a very interesting study based on data showing that neoadjuvant immunotherapy can result in dramatic tumor responses in patients with deficient mismatch repair colon cancer. This study enrolled patients with stage 2 and 3 rectal cancer, deficient mismatch repair, and treated them with a PD-1 antibody, dostarlimab, so a single agent immunotherapy, IV every 3 weeks. These patients were monitored very closely with tumor biopsies, MRI, and PET-CT, in addition to the usual endoscopy. And those who had residual disease after 9 doses, or about 6 months, they would get chemoradiation, and if they still had residual disease, they would go on to surgery. But what was very dramatic in this study, at that time only 12 patients were in the paper, is that all 12 had a complete clinical response, so no evidence of disease on the imaging and on the endoscopy. And this is an example of one of the patients who had a dramatic response, like even at 3 months. And, compare this to what we would expect with chemoradiation and chemotherapy, and there were no severe toxicities in these 12 patients. They did have some immune toxicities like rash, pruritus, fatigue, and nausea, but all mild or moderate. So, this is very exciting data. We don't have long-term follow-up, so TNT is technically still the standard of care, but this data is very compelling in terms of the dramatic response and the improved toxicity. And so I do feel that all of our patients with deficient mismatch repair rectal cancer should be offered immunotherapy, ideally on a clinical trial, but if that's not available, I think it's quite reasonable to try this off study. We've had a study here at Cleveland Clinic of pembrolizumab with chemoradiation led by Dr. Liska that we have enrolled to. But it is very interesting to consider the immunotherapy without radiation. And also I should add, this is a treatment for a rare subset of patients. In our TNT database, only 3% of patients had deficient mismatch repair rectal cancer. Okay, so then what about for everyone else? So now I'm going to focus on patients with proficient mismatch repair. Let's look at these large randomized trials of TNT. So Rapido is a very large trial that enrolled patients with high-risk disease. So clinical stage 2, 3, but they had to have at least T4 tumor, N2 disease, extramural vascular invasion, positive mesorectal fascia, or lateral lymph nodes. And they were randomized to the traditional chemoradiation with fluoropyrimidine, followed by surgery with optional adjuvant chemo, versus starting off with short course radiation, then chemotherapy for 18 weeks, and surgery. And the TNT arm, compared to standard, did improve the pathologic complete response, doubled it to 28% versus 14%. And 3-year disease-related treatment failure was about 24% in the TNT arm versus 30% in the standard arm, and most of these treatment failures were metastases. There's a 7% reduction in metastases. The graph here is showing that disease-related treatment failure out to 5 years. You can see the standard of care group is having higher disease-related treatment failure. Rapido did have a slightly higher risk of local recurrence with the short course therapy in the TNT arm, as shown here. And long-term quality of life at 3 years was really no difference between the two arms. All right, next then we'll look at PRODIGE 23. This is a randomized trial also for patients with clinical stage 2 and 3 rectal cancer. And the standard arm was chemoradiation with capecitabine, that's the top bar, followed by surgery, and then mandated adjuvant FOLFOX or capecitabine for 6 months, compared to the experimental arm, which was intensified chemotherapy, triplet regimen, FOLFIRINOX, 5-FU, irinotecan, and oxaliplatin. So adding irinotecan in the mix, this is a regimen we know has a higher response rate in metastatic colorectal cancer, also significantly increases toxicities like diarrhea, nausea, and fatigue. After chemotherapy, patients had the standard chemoradiation with capecitabine surgery, and then 3 months of chemotherapy. So everybody got 6 months of chemotherapy in the study. The neoadjuvant modified FOLFIRINOX arm resulted in, again, a very high pathologic complete response of 28% versus 12% with the standard arm. So very similar to Repeto. And also this study looked at a 3-year disease-free survival as the primary endpoint, and 7% improvement with the TNT arm versus standard. And with a 10-year follow-up at ASCO this past year, we heard that there was a survival advantage. Sorry, it was 7-year follow-up, 82% versus 76% for the TNT arm. And this is showing the disease-free survival, with the red being the neoadjuvant group. This study also reported 2-year quality of life, and the FOLFIRINOX arm actually had improvement in impotence in men compared to the standard arm, presumably due to better tumor shrinkage. There was really no other difference in quality of life. Okay, now TNT with the goal of watch and wait was addressed by the OPRA trial, which was a randomized study for patients with stage 2 and 3 rectal cancer, where they were randomized to start with chemoradiation and have consolidation chemotherapy, FOLFOX or CAPOX, or the opposite, start with induction chemotherapy followed by chemoradiation. And then at restaging, patients who had a complete clinical response were offered watch and wait, otherwise had TME. And this study, I was so surprised when these results came out that there's over 50% of patients could have organ preservation at 5 years. That's what the long-term results are showing. So of course, this is of great interest to our patients, particularly those who would be needing a permanent colostomy. And so now I just want to cover some studies looking at neoadjuvant therapy without radiation, because of course we have a lot of toxicity when we do TNT. So the first study was this FOWORK study from China, which was a randomized trial for patients with stage 2 and 3 rectal cancer, randomizing them to chemoradiation with infusional 5-FU or FOLFOX, so with oxaliplatin, or FOLFOX alone. So they had an arm without radiation. And this was meant to be demonstrate the superiority of the arms with the FOLFOX. What they found, though, is it was a negative study. There was no difference in DFS, local regional recurrence, or overall survival at 10 years with the addition of the oxaliplatin. But that also meant that the arm that didn't have radiation was also having similar outcomes to the arms with the radiation. So it was a first signal that maybe radiation is not needed for all patients. And then when they examined a subset of patients who had completed questionnaires about their bowel function, and this was at the end of the study, so it was several years of follow-up. You can see here the arm, the column here is with 5-FU radiation, and on the right is with the FOLFOX without radiation. Significant improvement in stool frequency and all types of incontinence with the omission of radiation. Prospect study provided definitive data because this is a very large study, over 1,100 patients with rectal cancer that was not T4 or N2, and patients had to be candidates for sphincter-sparing surgery, and randomized them to the standard at the time chemoradiation with fluoropyrimidine followed by surgery and adjuvant FOLFOX or CAPOX, versus the experimental arm of starting with chemotherapy, FOLFOX or CAPOX, for 3 months, and then using chemoradiation only if the patient didn't have at least a 20% reduction in tumor. And this study found there was no difference in disease-free survival, local regional recurrence with the experimental arm, with the use of selective radiation. And that's what we're seeing here are the disease-free survival rates at 5 years, which are about it was actually 80.8% with the selective radiation, 78.6% with the standard arm, and no difference in overall survival, no difference in pathologic complete response, and only 9% of patients receive selective radiation. So this is, looking very effective for that subset of patients. And then quality of life, very important. This study actually collected patient-reported outcomes, And overall, there was no difference in health-related quality of life, but there was an improvement in bowel function with the omission of radiation, and sexual function in both men and women with the use of only selective radiation. Now, they didn't capture rates of amenorrhea in this study, but we do know that with chemoradiation, menopause will occur in almost 100% of premenopausal women. And we have some studies have evaluated the rate of amenorrhea with adjuvant FOLFOX, and in women less than 40 years of age, it ranges 0 to 13%, and 24 to 38% over 40. So certainly omitting radiation can lead to fertility preservation for these patients. And the last trial in this group, CONVERT trial, this is from China. We have preliminary results so far. These are for patients with T2 node positive or T3, T4 node any status, not adjacent to the mesorectal fascia, randomized to the standard chemoradiation with capecitabine surgery and adjuvant capox versus starting with capox. Then they give chemoradiation only if the patient had like actual disease progression or mesorectal fascial involvement. And so this is a little bit more narrow use of radiation than prospect. And they only had like 1% of patients getting radiation in the experimental arm. Path CR rate was 11% in the chemo arm, 13.8% in the standard arm. Distant Mets were a little bit lower with starting with the chemo, 0.7% versus 3.1%. And they haven't yet reported their primary endpoint of 3-year local regional failure-free survival. There were similar rates of severe toxicities in both arms in this study. All right, so options for patients with stage 2-3 rectal cancer with proficient mismatch repair. Start with chemoradiation with fluoropyrimidines or short course radiation followed by doublet. This is our approach at Cleveland Clinic. We start with the chemoradiation and then the chemotherapy, which led to higher organ preservation in the OPERA study, and then offer watch and wait to patients who have a complete clinical response. One could also start with FOLFIRINOX or doublet therapy and then proceed with chemoradiation. I think you can also use FOLFIRINOX after chemoradiation, and the Janus phase 2 study that's going on, randomized trial, is asking that question, FOLFOX versus FOLFIRINOX and TNT. But I think we need to think about for patients who are candidates for sphincter sparing surgery, who do not have T4 tumors, N2 tumors, have a clear margin, to use the radiation only selectively because there are excellent outcomes with this approach. And of course, we have to test for deficient mismatch repair in all of our patients and refer those who have deficient mismatch repair for immunotherapy. So basically, those are my takeaways. We should check everyone for mismatch repair, offer immunotherapy to those who have deficient mismatch repair, saving chemoradiation surgery for persistent disease. And for those patients who would like to avoid radiation, for example, would like to preserve fertility and are willing to have surgery and who don't have T4, N2 disease, who have a clear margin, who do not have distal tumors, we can use FOLFOX with selective radiation to improve sexual health and bowel function and fertility without any decrement in efficacy. And for those who desire non-operative approach or who have a T4 tumor, N2 disease, threatened margin, distal tumor, recommend total neoadjuvant therapy. One can use either doublet or triplet. We use a doublet. OPERA had excellent results with just the doublet, and it's less toxic. And we start with chemoradiation to maximize the chance of complete clinical response, but optimal regimens to be determined. And with that, thank you very much for your attention.
Thank you, Smita. This was an excellent summary of TNT. So we have seen TNT can be used, but not for all. And there are different alternatives as well, depending on the patient characteristics and cancer characteristics and biology. So now we got that out of covered. Now, we may treat patients with TNT, but still may end up with a little bumpy mucosa or little raised lesion, but nothing really concerning. And is that really something that we're gonna bite the bullet and do a major operation and proctectomy, or can we really manage these patients a little differently? So my partner, Dr. Josh Somavilla, will give us the talk and will explain this scenario and gonna talk about residual luminal disease after neoadjuvant therapy for rectal cancer. Is there a rationale for the utility of endoscopic submucosal dissection? Josh?
So I'm going to talk about what we do about residual luminal disease after TNT and whether there's a rationale for doing endoscopic submucosal dissection in these scenarios. Like Dr. Gorgan mentioned, and like Dr. Krishnamurthy mentioned in her last slide, a lot of patients that we're treating have the goal of non-operative management, and this talk is mainly focused on those patients who are giving TNT to, and there's just a little bit of disease left after TNT. So I'm going to talk a little bit about how we define and characterize residual disease following TNT, and discuss data regarding local excision following TNT, and talk about the different techniques for local excision, of which ESD is one. And I'm going to talk about our experience with ESD as a local excision technique after TNT and the rationale for this approach over some other techniques that might be used. So we'll just start with a case here. So this is a 72-year-old female who presented with rectal bleeding. She was found to have a mass on exam that led to colonoscopy, and this was biopsied and showed adenocarcinoma. She had no metastatic disease on her staging, and she ended up on her MRI having a T3N1 disease. So as many would do, and as we do here, we proceeded with total neoadjuvant therapy for this patient and assessed her response afterwards. So she underwent chemoradiation followed by consolidation chemotherapy. And what we look for after TNT to define a complete response is a completely smooth scar. And clearly this is not the case. There's some nodular mucosa here. It's about 25 millimeters in size in the distal rectum. And on biopsy, it just showed high-grade adenomatous dysplasia. And again, there was no sign of metastatic disease on her distant staging. And she had a MRTRG2 MRI, so just dark scar present, no residual MRI evidence of active remaining tumor. So what do we do now with this patient? She had a near complete endoscopic response and no signs of residual disease on her MRI. Should we continue observing her? Should we jump into doing a proctectomy with a TME? Or could we consider a local excision? And if so, what technique should we use? So I'll just talk a little bit about the different techniques that have been used at different places for local excision, both in the non-TNT setting and in the TNT setting. So you have traditional transanal excision, transanal minimally invasive surgery, transanal endoscopic microsurgery, and either TAMIS can also be assisted with a surgical robot. And then we have partial thickness techniques, which could be either endoscopic submucosal dissection or robot-assisted endoscopic submucosal dissection. So this just shows how some of these techniques work. So traditional local excision is probably the technique that is familiar to most colorectal surgeons. You get a direct transanal view of the lesion using an anoscope. It's a commonly held skill set, and the downsides include you don't get great precision for both the deep margin or for the radial margins, and exposure can be difficult, as well as margin assessment. Both TAMIS and TEMS are different alternate techniques with a similar principle of doing minimally invasive surgery transanally. You insufflate through a transanal device and use either laparoscopic instruments or the rigid instruments that are with a TEMS platform to do what's typically a full thickness excision, including the mucosa, the muscle layer, and the fat layer of the rectal wall. This just shows some static images from TAMIS and TEMS, and you can make full thickness defects and repair them, or some people, depending on the location, would leave these open. And this is just a figure showing some of the basics of ESD, where you do this, obviously, endoscopic technique. You identify the lesion. You use a submucosal lifting agent to lift the lesion, incise around it, and then dissect in the submucosal plane that is right on top of the muscle layer, to do a partial thickness excision, including the submucosa and the mucosa. And this is just a short video here that I could show you the technique that I'll be spending the most of the rest of the talk talking about. So this is an endoscopic view going in through the anus. And you can see this residual small amount of polypoid tissue here in the distal rectum. And this is in retroflex view. You can see up here this irregular mucosa, and now using the injection needle. Usually these lifting agents are colored with methylene blue that helps you identify the margins. And they also usually contain some type of starch that will help with a lift. So this is continuing to lift around the lesion so that you can get a good circumferential margin. And then this is one tool that we use to incise the mucosa. This is called a needle knife or a pro knife. And this incises the mucosa, which you'll do circumferentially to get a good margin around your lesion. And here you can see on top of the muscle, this blue colored submucosal plane, and you can dissect underneath the lesion in this manner until you have it fully resected. For bigger lesions, you can get this scope with a cap on the distal tip of it into the submucosal tunnel and just continue to dissect in that plane right on top of the muscle. So here you can see the lesion is probably about 75 to 80% off. Most of it is dangling up towards the top of the screen, and there's just a little bit of mucosa that are attaching the back of the lesion there. And this is just getting the remainder of that proximal margin. Again, using the endoscopic dissecting knife, and this is getting the last bit of the lesion off. So here you see the remaining defect, and the muscle is intact. Now, sometimes you have very small muscle defects, as you can see here, and those, depending on the situation, can, if you're confident that you're below the peritoneal reflection, you could keep them open, or if you have any concerns, you can close them with the endoscopic clip, as is being done here. And then this allows you to get an en-bloc specimen that you could pin to a cork board with clear radial and deep margins and have it thoroughly evaluated by a pathologist. So I'm just going to talk a little bit about local excision after TNT as a general principle, whether this is oncologically sound, and what might the negative consequences be, and how might they be avoided by altering our technique or choosing the right technique for doing them. So in doing the full thickness techniques after a patient's been radiated, there are a couple of problems, or potential problems, I should say. Number one, the risk of non-healing the wound that you're creating in a full thickness wound in a irradiated field. And secondly, as you can see in this MRI, the mesorectum really tapers off as you get more distally. So when you're going with a full thickness incision, especially for a distal lesion, there's risk of compromising the TME plane if the patient were to need an oncologic resection in the future. And so these are two things that we need to think about when we're considering doing a full thickness local excision. It's been shown, this is a study by Rodrigo Perez, that patients who have full thickness excisions after TNT have a pretty significant risk of having postoperative pain, hospital readmission, and wound dehiscence. But from an oncologic standpoint, there are studies that show that this can be quite good. So I'll just briefly overview the GRECR2 study, which looked at local excision after TNT. So they aimed to assess the oncologic and functional outcomes. And they did full thickness local excision for complete and non-complete responders following chemoradiotherapy. So this is not TNT, but it's chemoradiation. They considered local excision adequate if the pathology on the locally excised specimen was T0, T in situ, or a low risk T1, and recommended TME if it was a higher stage than that. So this just shows that how they randomize patients. And so patients with a good response after chemoradiation were randomized to TME or local excision. And then there's another subgroup within the local excision, depending on what their stage was. So some of these patients, if they had a higher stage on their local excision, would go on to get TME after that. And this is important for what we're going to talk about in a little bit. So basically what they found is that if they compare the local excision group to the TME group, the oncologic outcomes were quite similar, and there's no worsening outcomes in death, tumor recurrence, morbidity, or side effects at 2 years. The challenge was when they looked at this third subgroup, the patients who had local excision and then needed a TME, they had much higher morbidity, mortality, worse oncologic outcomes. That was really significant compared to the other two groups. Similarly, other studies that have showed in patients who undergo full thickness excision followed by TME, that there's a significant risk. Almost a third of patients have a poor quality specimen in their TME, which is not good for oncologic outcomes, and in this study translated to poor outcomes. And this was associated with low tumors in patients who underwent full thickness excision. So to contextualize this, this is a large study that showed the safety and oncologic benefit of doing local excision after chemoradiation, but there was a relatively high need for TME. Potentially doing TNT with consolidation chemotherapy on top of chemoradiation can help reduce the need for this. That ties into what Dr. Krishnamurthy was talking about. But also, the patients who had a TME after a full thickness local excision had a high complication rate and a substandard TME completeness. So this all feeds into the rationale for doing ESD as an alternative to full thickness local excision for a number of reasons. ESD is very effective at resecting T1 lesions because you get the submucosa as en-bloc specimen all the way down to the muscle layer. You can still identify lesions that are high-risk T1 and greater stage because they'll have a positive margin or they'll display high-risk features. It maintains the muscle integrity in the rectum, and it maintains the TME integrity if the patient's going to go on to need further treatment with oncologic resection. So back to our case. So as you might imagine, TNT was performed on this patient, and this is just showing the specimen here. And the patient ended up having, in the specimen, tubulovillous adenoma with focal high-grade dysplasia, and has been followed clinically since then and has not had any sign of recurrence after about 1.5 years. This is just that 6-month endoscopic follow-up after the ESD, showing the flat scar with some telangiectasia that we like to see for our complete responders. So I'm just going to briefly talk about our experience here doing ESD after TNT. So we do this for both patients who have a near complete response after TNT and patients who have a complete response but then show some local regrowth that appears to be either just adenomatous tissue or early stage. So this first chart just shows our experience with the patients who have a near complete response, meaning they never have a complete response to TNT. So in these 4 patients, we had one who had a T1 adenocarcinoma that had some high-risk features in the ESD specimen that required an APR. The other 3 just had precancerous tissue and have been followed ever since then without any need for a proctectomy or signs of recurrence. This next slide just shows our ESD experience with patients who have regrowth following TNT. So in this column, you can see their initial stage. They all had complete responses initially and went on to our watch and wait protocol. And then after some period of time, developed some interval regrowth. And then they underwent ESD. So one of these 6 patients had a T2 cancer, but refused surgery and has still shown no sign of recurrent disease after that ESD. 4 of those patients had adenomatous tissue that was excised, and they've been followed with no sign of recurrence. And 1 patient had a re-recurrence after the ESD that undergoing oncologic resection. And this just shows some of the photos for what we see in these patients. So each row is a patient. So this is at diagnosis after TNT. This patient underwent ESD. That's the defect forming ESD, and then follow up here. So you can see that we've had good endoscopic results in many of these patients. Even some of these lesions that are quite locally advanced and then have some significant adenomas appearing residual disease have been shown to respond pretty well to having ESD of that residual tissue if it's still early stage. So in conclusion, local excision following TNT may provide opportunity for additional organ preservation in patients who desire that. Full thickness local excision following TNT is associated with some significant side effects, including readmissions, wound dehiscence, and pain, and also may complicate subsequent proctectomy when it's needed. ESD offers a potentially attractive alternative to full thickness local excision, allowing TNT to pursue an organ preserving approach by both maintaining the integrity of all the planes that we need for future surgery, while allowing us to identify low and high risk patients with regrowth after TNT. Obviously, we need more study to know the long-term outcomes, both oncologically and functionally in these patients, but it seems to be a promising alternative. Thank you, and I look forward to talking more about this in the panel discussion.
Thank you, Dr. Sommerville, for this eye-opening talk and presentation. Certainly, thank you also for pushing the envelope for organ preservation in the treatment of locally advanced rectal cancers. We have been really pushing the needle towards more organ preservation, and we have been seeing these significant responses to total neoadjuvant therapies in different ways, chemoradiation first, after consolidation, or vice versa, or immunotherapy, like Dr. Krishnamurthy mentioned. But how about giving this advantage to early cancers as well? Why not to offer them and prevent them from having a major organ resection? So my partner, Dr. Ariella Kanters, Associate Program Director for our fellowship program, will talk about that next. And her topic is management of early stage rectal cancer. Does TNT have a role? Dr. Kanters?
Everyone, thank you for the chance to speak tonight. I'll go into a little more detail about a particular subgroup of patients, and I'll highlight a little bit of what Dr. Krishnamurthy talked about, what Dr. Somavilla talked about, and set the stage for our upcoming discussions. So I'll be talking about the management of early rectal cancer, and is there a role for TNT? There we go. So when we talk about TNT, we're specifically looking for the goal of organ preservation with the watch and wait approach. And this is in the context of achievement of a complete clinical response. Importantly, though, this was initially described for patients with a locally advanced rectal cancer, not necessarily the early stage rectal cancer we're talking about right now. Interestingly, though, at the time when we were first discussing this, our MRI imaging was not quite as effective, and there were a subgroup of patients with early rectal cancer that may have actually been accidentally included in these studies. Specifically, we're talking about these early rectal cancers, the P-T1 to 2, or even M-T1, T2, N0, M0. So the tissues, the cancers that specifically don't extend beyond the muscularis propria and without any evidence of nodal disease. And for the purpose of what we're talking about, this is based on MRI, though some are still using endoscopic ultrasound. So we're going to talk about this subgroup of patients and whether or not TNT with the goal of organ preservation is an option. Before getting into whether we should be offering this, let's first think about who we should not be offering this. Obviously, TNT, chemotherapy, radiation, et cetera, all carries chemotherapy, radiation, and chemoradiation carries morbidity. And so there's, with the more superficial tumors, specifically the T1 with a favorable SM1 cohort, this is a population that may actually be better served with for organ preservation right off the bat. And so this is somewhere that Dr. Somavilla and Dr. Gorgan have been particularly enthusiastic, and particularly with regards to an endoscopic or transanal, robotic, laparoscopic, or open approach, where we can achieve very favorable oncologic outcomes by truly excising the lesion right off the bat. There are also the cohort of patients with a high or mid rectal tumor, those above the anal rectal ring, so the insertion of the levator muscles. This is a group that it can be difficult to actually identify the lesion on digital rectal exam, which is a key aspect in the watch and wait surveillance model. Admittedly, we do have many have flexible sigmoidoscopies or sigmoidoscopes, which allow for continued surveillance, but in the event that a flex sig is not readily available on an every 3-month basis, if you can't actually palpate the tumor, this patient may not be a candidate for watch and wait, in which case avoiding TNT and the morbidity of radiation and taking them straight to surgery for a total mesorectal excision may actually be in the patient's better interest. So if we're not going to offer TNT to that group, who can we consider offering TNT? So the MR T2N0 patients, those where local excision would be insufficient for, or would be inadequate for appropriate oncologic resection, or the patients where the tumor may be inserting into the levators, where they would potentially require an APR as opposed to a low anterior resection in order to achieve appropriate negative margins. These are two cohorts that their surgical options, unfortunately, are not the best. So organ preservation through the acceptance of the morbidity of TNT is a desirable outcome. Additionally, there's the patients who may have high-risk features on MRI, for example, extramural invasion, evidence of tumor deposits, or threatened mesorectal fascia. This is a cohort that may carry a higher risk for both local and recurrent, or local recurrences and distant metastases, and therefore benefit from the additional focus and systemic therapy of TNT. So now that we're thinking about this T2N0 cohort, how do we think these patients will actually respond? You know, it's watch and wait. We're looking for the gold standard would be a complete clinical, we're looking for a complete clinical response, but the actual data on pathologic complete clinical response, they provide more confidence in our decision as we're trying to coach our patients in making this decision. We'll talk a little bit more about this trial shortly in the context of local excision, but the ACOSOG V6041 trial treated patients with neoadjuvant chemoradiation and then proceeded with local excision. And they found that with just chemoradiation alone, there was actually a 50% chance of a pathologic complete response. Dr. Abergama out of Brazil also looked into delivery of neoadjuvant chemoradiation, again without TNT, and looked at how long it took for a complete clinical response within the cohort, and found that with T2N0 cancers, there was also a quicker complete response. So we're seeing not only a high rate of pathologic complete response, but also a quick clinical complete response with just radiation alone. So then you may be asking, but then why would we include chemotherapy? You've just told me there's a low chance of micrometastatic disease, and why would I add additional morbidity? Well, Dr. Krishnamurthy's already gone into detail about the benefits of adding chemo to the neoadjuvant chemoradiation regimen, but in brief, we see that the combined therapy improves the rate of complete clinical response, allowing for an increased chance of organ preservation without TME. So if our goal is organ preservation without taking the patient to the operating room, and we know that we get a good response with neoadjuvant chemoradiation in T2, this group would actually be a potentially ideal candidate for a regimen that includes chemotherapy. This is the group that if you're already accepting the morbidity of radiation and you know you've got a better chance of achieving your goal of organ preservation without TME, adding in the chemotherapy would improve our chance of success. And in one study out of Annals, they found that there was actually a 67% chance of organ preservation without TNT organ preservation without TME following TNT as opposed to just 30% following neoadjuvant chemoradiotherapy. And this is specifically within the T2N0 population. So if you buy it that this is the right group for a TNT, how do we choose short versus long, induction versus consolidation? This is a little bit of a harder question to answer because we really don't have the prospective randomized controlled trials comparing short course and long course, both with consolidation. Here at Cleveland Clinic, we're biased. We opt for the long course chemoradiation. There's some data to suggest an improved TME specimen with long course. So if you do end up having to go down the salvage route, you have potentially an improved pathologic specimen. And then the 5-year data out of the Rapidos trial is also suggesting possibly a higher local recurrence with short course therapy. Importantly, though, recognize, again, that's not quite in the true context of TNT, but yet another point that may lead you more towards the long course. And then as for induction versus consolidation, both a pathologic and a complete clinical response were found to be significantly more frequent after regimens incorporating consolidation chemotherapy. And one of the reasons thought to be for this finding is associated with the significant larger interval of time between assessment of tumor response and the final date of radiation. So with the longer course and then whichever course of chemoradiation, but a consolidation chemotherapy, by the time you're actually going back to look for the complete clinical response, the radiation has had its full time to take effect. Furthermore, the complete clinical response found the differences in organ preservation rates may also be due to the higher occurrence of local regrowth rather than just the higher chances of achieving a complete clinical response. And then what do you do if you're not successful? Even though these patients with T2N0 rectal cancer may be undergoing this TNT or neoadjuvant chemoradiation therapy for the sole purpose of achieving a complete clinical response, there is a chance that these patients may never actually achieve the intended outcome. So one could argue that many of these patients have now been harmed by the morbidity, and in the setting of an incomplete clinical response, they now face surgery in the setting of the additional consequences of chemotherapy and radiation. So not only surgical outcomes, effective surgical outcomes, including increased risk of anastomotic dehiscence, but also functional outcome effect, including issues with continence and bowel control. Fortunately, though, even with an incomplete clinical response following TNT, this cohort still has a chance for organ preservation strategy via the transanal local excision. And coming back, this study with Dr. Somavilla briefly went through it, but we've actually found that small initial tumors, those less than 4 centimeters that are an MR T2N0 with a good treatment response, there is no difference in outcomes in comparing the TME versus local excision. So though they may not have had that goal of a complete clinical response, they still can achieve the goal of organ preservation. Going back to the ACOSOG Z6041 trial, and remember again, this is the context of just neoadjuvant chemoradiation, but local excision following neoadjuvant chemoradiation also showed very low rates of local recurrence after excision of less than or equal to 4%. So this may still be a safe option even if there isn't a complete clinical response. Then finally, we have to think about our salvage options. So not only may there be the cohort that doesn't have the complete response, but 30% of watch and wait patients may experience tumor regrowth. And then within this context, what are our options then? Are there only salvage options of TME? Well, fortunately, T2N0 may still have an option for local excision, and studies that have published in DCR have demonstrated a similar recurrence-free survival and actually a lower rate of distant metastases, so 9% versus 30%. So you're still potentially gaining this benefit from the systemic therapy, even if they ultimately do require surgery down the way. So with that in mind, the key takeaways is that early stage rectal cancers can be considered for organ preservation strategies using TNT. Ideally, this is with the MR T2N0 population or those with levator or sphincter involvement. There is a higher complete clinical response with long course neoadjuvant chemoradiation and consolidation chemo together. That said, local excision remains an option even those without a complete clinical response, and for the cohort who do experience tumor regrowth in the setting of a watch and wait surveillance strategy, local excision may still be an option. Thank you.
Dr. Kenters, thank you very much for this excellent presentation. This is certainly a topic that can get some criticism, and this is a new territory, but certainly I do believe this is where we are heading to, and this will be used more extensively across different centers in the United States as well as globally, in my opinion. With that, I will please invite all the panelists to turn their cameras on, and we're gonna go and discuss some cases, clinical scenarios. At the same time, we will try to answer some of the questions in the chat box we have been answering, but please bring them on as you listen to us. And if you, from all these 3 excellent talks and presentations, if you have any questions, as you have been doing, please type them in so we can answer them as we go. We're gonna go ahead and start our case presentations. All right, so first case, gonna be a clinical scenario. 37-year-old healthy male undergoes colonoscopy for rectal bleeding and shows a rectal mass 3 centimeters from the anal verge, as you see on this bottom of the slide, and a little bit closer view. Pathology shows invasive, moderately differentiated adenocarcinoma, MMR proficient. So I'm going to jump right into our pathology, Dr. Erika Savage. If you could tell us, like if we get a pathology from outside, either with or without this MMR status, what is the protocol? What should we do? How should we request this MMR? Do we need to get the slides from outside, or do we need the paraffin blocks? How do you do, and what is your protocol? What should the surgeons follow, or clinicians should follow in getting these information in our hands?
Yeah, for mismatch repair status, I guess I would look at the outside pathology report and see if they've actually performed on the outside. If so, getting the slides is perfectly acceptable and having the local pathologist reinterpret those. If it hasn't been done, then getting the tissue block to perform those studies is kind of what we do as our standard. And it's usually at the request of the clinical team in order to get that for reimbursement purposes.
All right, excellent. Dr. Somavilla, you have this endoscopic view, and patient comes into your office. What is your next step? How is your approach for a patient 37 years old with this pathology?
So I think the first step in moving forward would be getting the staging, as that will give us an idea of the best way to proceed with treating him. So typically for us, that's getting a CEA level MRI of the pelvis and CT scans of the chest, abdomen, and pelvis to look for metastatic disease.
Okay, this is the MRI, and Dr. Venera, I know you didn't get these images beforehand, but when you get an MRI, for a patient, especially in an early rectal cancer, you think, what are the pitfalls? What are you looking for, and how do you approach these patients when you're reading and giving your report to a surgeon or clinicians? Unmute, please. Joe, can you unmute?
Sorry about that. Yeah, in a low-stage tumor, oftentimes we'll see the tumor, but it's hard to distinguish invasion into the submucosal, through the submucosa and into the and to determine whether it's a T1 or T2 lesion. And so primarily our job is to then look and see if there's any extra luminal disease that is going to upstage the patient and potentially change the management. We'll do our best on some of the higher resolution scanners with good distension. Sometimes we can make a determination that it's most likely going to be a T1 lesion, but oftentimes it's impossible to distinguish between a T1 and a shallow T2.
Yes, commonly we also come across even non-malignant lesions that they are read as T1, T2s, and zeros. Is there a hope in the future to make that sensitivity or specificity of these studies any better?
It would require some kind of a marker probably, because the issue is that an adenomatous lesion is still different tissue, and so we'll recognize it as a tumor, albeit a benign tumor, and unless you can know where the malignant parts of it are, you don't know which part is extending into the wall. And so it's impossible without being able to distinguish between the benign and malignant tissue, which it is. When you know a lesion is essentially all malignant, then it's easy to make the assumption that everything we're seeing is tumor invasion. When you have a polyp, you have a mixture.
Okay. So in terms of the treatment options, Dr. Kanters, these are some of the possibilities. What is in your current practice that you approach a patient 37 years old, T1 cancer, based on the MRI, no nodal involvement? What would be your approach to treat these patients?
So young, long life ahead of them, but pending the pathology report and recognizing high risk features in the T1 lesion would push me more towards a traditional oncologic resection, but having a very frank conversation about the possibility of a transanal excision with close follow-up. So if everything looks very favorable, LVI, no LVI, PNI, low tumor budding, et cetera, offering a transanal excision, I do think would be a good option. If not, I think you said 3 centimeters above the anal verge. So assuming good sphincter complex and an LAR with a coloanal would be an alternative option if they felt that they were not comfortable not knowing the nodal status outside of the MR imaging.
Very good. Dr. Emernat, so the patient is adamantly refusing surgery, and she's asking about, or he's asking about the possibility of a TNT or radiation treatment. Is this something that you would consider in very select circumstances?
Yeah, no, certainly. And I think, Dr. Canters and Dr. Somavila very nicely kind of presented that data for upfront chemoradiation in early stage tumors. And so I think in a young patient who wants to avoid long-term colostomy, it's certainly a potential option, knowing that there are risks of long-term sterility, long-term, potential bowel complications and whatnot. And so I think having a really open and honest discussion of what is the toxicity risk of chemoradiation versus what is the risk of, any potential surgical options is really important in these patients.
Similarly, Dr. Krishnamurthy, if this was an MMR stable, but if it's deficient MMR, such early patient, possibly a good candidate for low anterior resection. Do you think it's worth to have a discussion potentially for any PD antibody or any type of immunotherapy options?
Yeah, absolutely. I think the data, it looks so compelling what we're seeing with neoadjuvant immunotherapy for early stage colon cancer and rectal cancer with deficient mismatch repair. So I think it'd be worth seeing medical oncology for the discussion about immunotherapy to potentially avoid surgery altogether. And also just, as the oncologist on the panel, my hammer is chemotherapy. And so I just also wanted to add, I know we have a lot longer term data with chemoradiation for these sorts of T1 tumors, but it is interesting that there's that phase 2 NEO trial, 3 months of FOLFOX. Then I think they did a full thickness excision, and patients who had more than T1 residual disease went on to TME, and that had a 57% organ preservation rate. So that's going to go on to phase 3. So of course we need longer term data, but it's just so interesting. There's so many ways one could approach this.
Excellent. All right, that's very good. So we talked about indications, and Dr. Somavila, so you think this for select patients, and this is if it's a T1, no other risk factors. Dr. Canters also mentioned that, and NCCN guidelines also recommend that T1 cancers, you can do local excision. How would you approach in terms of the transanal local excision?
So in a patient who's not yet received radiation, I feel like the options are I'm a little bit more open to doing a full thickness excision, which I worry about more in a radiated field. I think in this situation, the endoscopic photos that you showed at the beginning looked a little bit concerning to me, like it's a higher, likely to not be a low risk T1, and I worry a little bit about ESD, but I do think ESD would be reasonable if you don't have clear radiographic evidence that it's a T2 lesion. So I would either do an ESD partial thickness just to get a confirmed pathologic stage, and then you could consider other options after that, be it proctectomy or some form of chemotherapy or chemoradiation, or a TAMIS.
Yeah, and then another advantage of ESD probably would be there if you decide to go for a TME, you wouldn't burn your planes, surgical planes, and possibly TME planes would be left intact as well. Excellent. So we're gonna shift gear a little bit here, and here our second case. It's a little bit different size in terms of the patient, and It's a 63-year-old morbidly obese patient with mid-rectal cancer, 7 centimeters from the anal verge, pathology, invasive, well-differentiated adenocarcinoma, as you see in the endoscopy. And this is our MRI findings. Again, this is not a video image, just a snapshot, but I'm going to turn back to Dr. Minero. And how do you determine really the peritoneal reflection, or if it's more like an upper rectal versus rectosigmoid, and does that really make a difference? We can have a subsequent question to that, but how do you determine and what's your landmarks assessing that?
So when you scroll through the images, a lot of times you can actually find the peritoneal reflection as a thin hypointense band. Also, if it's intact, it's holding up the small bowel, and so you can see the extent of the small bowel and intraperitoneal fat coming down. Oftentimes, as you scroll up in an axial plane, you also see where you identify where the mesorectal fascia merges into the peritoneal reflection, and that's usually one of the better ways to identify it in my mind. And then you have to realize, of course, that it comes down at an angle and it's higher posteriorly than it is anteriorly. So we look to see where the question is going to be to try and determine where it is exactly.
All right. So this is obviously a T2N0 based on complete review of this MRI findings, and it's a morbidly obese patients, as we discussed. It's a lower tumor. It's a low stage tumor, T2N0, but these are our options. Dr. Somavilla, do we still do TA-TME?
I think here you're the only person who does it. We don't do a lot of it, but I think we still have it in our armamentarium. There are some concerns about local recurrence rate and things like that. So this might be somebody who, if you had to do a proctectomy, it'd be a consideration for, though I don't know if the tumor is low enough that it would be needed.
Dr. Amarnath, do you think this is such an obese patient? Do you think we could avoid, I mean, similar to the last patient, but that even probably more so in this one, it's a T2N0, morbidly obese, BMI 57 or so. Certainly, her operative risk is very high, and she's prone to have some surgical complications after the surgery. I mean, Dr. Kantos really nicely summarized the data on that. But do you think this patient would be someone that you could approach TNT?
Yeah, I mean, typically we think about that more in the setting of a T2N0. That's a distal tumor to really kind of avoid APR. But, certainly if the surgical risk is very high for the patient, then I think that represents, a potentially good treatment option, although we have a little bit less data in the non-distal rectal setting. But ultimately, I think if you're thinking about non-operative management, it would really be also what does surveillance look like for you all, longer term.
And Dr. Kantos, do you approach your rectal cancer operations in what type of minimally invasive surgery, and what are the advantages for those?
So my rectal cancer cases, I typically do robotically. I'd be willing to do, we'll still do laparoscopically depending on availability, but generally more in a petite, especially a woman. The laparoscopic approach or the robotic approach doesn't offer quite as much in that singular cohort. But in terms of robotic versus laparoscopic approach, the major benefit I found is just in the deep pelvis, especially in a male. Additionally, in the obese patient population or patients suffering from obesity, the additional strength and torque offered by the robotic arms over laparoscopic torque, especially when you're working against a very thick abdominal wall, is very significant in terms of both surgical ergonomics, but also ability to complete the operation safely. So robotic as long as it's available, but especially in a patient like this, if we either didn't have a complete clinical response or we were opting to go straight to surgery, this would 100% be robotic.
I think that was part of the reason why the TA-TME was invented at the first place, that for really challenging high conversion rates, morbidly obese patients, approaching from the bottom might be a salvage. So you can still preserve or maintain the minimally invasive approach these circumstances. But how can you maintain those skill sets to perform TA-TME in a, you know, if that's something that really you need to, or you can do only a few times a year? Do you think this is realistic?
I mean, it's with the accessibility of the robot and the growing accessibility, as well as our continued increasing comfort, it is hard for me to argue for a TA-TME. I mean, that patient, though challenging at first glance, doing that robotically is actually surprisingly feasible. I'm trying to think. I'm like I have a gentleman, I think he was 6'7" and 350 pounds, and we were able to do a low rectal cancer on him with the robot. I'm not going to say it's easy, but it's certainly more feasible than anything laparoscopic.
Dr. Krishnamurthy, this patient, let's say, decides to proceed with TNT because she definitely wants to avoid surgery. Do you think, and if there's complete response, do you think that's a problem because it's a higher tumor? Possibly we may not necessarily survey this patient with digital rectal exam, or would you feel comfortable putting this type of a patient into the surveillance program for watch and wait?
Well, yeah, that's a great question. I think, you know, certainly we're missing a component, right, of the surveillance if you can't feel where the tumor used to be. So it's not ideal, but I think, you know, we have been trying to push the envelope to offer non-operative management to more patients. So, you know, honestly, I don't know what the data is looking like, you know, in terms of like MRI, endoscopy, you know, without the DRE follow-up. But, you know, I think if the goal is organ preservation, I think I would still consider it.
Dr. Amarnath, anything to add?
No, I don't think so. But I mean, again, I think, you know, you all on the surgical side are the ones who do a lot of that endoscopic surveillance. And certainly with, you know, more locally advanced tumors, which I know we're going to talk about next, we have been offering non-operative management to some patients who have higher tumors now as well. So I guess I would defer to your experience.
Yeah, I think the data is also our data with Dr. Krishnamurthy we found here is really the sensitivity is the highest for endoscopy, followed by MRI, and also when you look at across the board, DRE always scores the lowest actually. So probably I know when this first came up, DRE was kind of important, and that's why watch and wait wasn't being offered maybe for upper rectal cancers, but I think that's going to fade away according to what I feel. But I think time will tell. Well, last question about this large patient, and a surgical question, but would you divert or not divert, Dr. Somavilla, if you would do a low anterior section?
How low is my anastomosis?
Well, it's about 9 centimeters from the anal verge, so you need to probably go 5 centimeters below the tumor.
It's pretty low, but this is a person who diversion's not necessarily a low risk thing either. A lot of stoma complications in morbidly obese patients. So if they hadn't undergone neoadjuvant, if they had undergone neoadjuvant treatment, I would absolutely divert them. If they had not had neoadjuvant radiation and I'm 5 centimeters or more and the anastomosis looks good, I would probably not divert.
Very good, very good. All right, maybe we have time for one more quick case, and then we need to wrap up here. It's a 54-year-old female did undergo TNT and low anterior resection with colorectal anastomosis, very low at 3 centimeters, and pathology did reveal invasive well-differentiated adenocarcinoma. Here's your specimen, beautiful. Unfortunately, the distal anterior margin is positive, however. So, Dr. Savage, Erica, what can you tell about this? How do you guys assess that? I know that when this was popularized, the TME, especially in England, this is like sushi cutting, and the assessment was done that way. Is that something that you guys still follow, like cutting it in rolls, or is that approach not practical anymore?
I mean, that's the ideal scenario because it gives you the best view of the mesorectum. In actuality, it's not going to be feasible for most cases because that requires over 24 hours of fixation, prepping it, and doing a lot of work before you even do the cutting. So I would say most centers throughout the United States, that process has been abandoned, and we do it based on just kind of the gross appearance, and usually have it fixed for a little while, but not for more than 24 hours.
What can you tell us from this microscopic view? Is that really showing you positive margin there?
From the images that you have here, it's hard to say where exactly your margin is. In terms of looking at the mesorectal envelope, we ink it a color to help us visualize that under the microscope. And we can also use cautery. I don't see either of those two things in the images, so I can't say exactly where it is, but those are the factors that we use to try to give you that accurate distance.
Okay, and then does it matter whether it's anterior or posterior lateral from your standpoint?
From our standpoint, no. I'm sure it matters for you guys to know exactly where it's from. So we tell our trainees and our PAs to gross it and to specify where its deepest extent of invasion is, and specify that when they take the section, so that hopefully, if it is positive, we can give you a better idea as to which margin is the closest.
Okay, so now since we have a positive margin after low anterior resection, these are our options. Dr. Cantos, any reoperation in this type of a patient with positive margin?
I mean, that's part of the conversation with the patient, but microscopic, I would hesitate to attempt any sort of reoperation. Certainly have a discussion, the possibility, is there an option for additional therapy, and otherwise very close surveillance.
Dr. Emmernath, any adjuvant in the setting of radiation, or we'll go back to Dr. Krishnamurthy as well for chemotherapy in a patient like this, but.
Yeah, I mean, I think in a patient who had full TNT, and had their full course of chemoradiation, at this point, I probably wouldn't recommend that. If there had been any evidence, that you might be close on an MRI, you might have thought about IORT at the time of the surgical resection. But I think at this point, I would probably not offer any radiation.
Smita?
Yeah, and for just as Dr. Amarnath said, the patient has already had their chemotherapy and radiation, and so we typically don't modify or give adjuvant chemotherapy based on the pathology results. I don't know that giving chemotherapy would, like, if this person is going to have a recurrence, I don't think that more chemotherapy will prevent that. Certainly needs close surveillance.
So with that, then, would you change your surveillance protocol? Would you do it a little bit differently than normally we would follow these patients?
Yeah, I think so. Normally after, rectal cancer surgery, we're getting CAT scans, chest, abdomen, pelvis like once a year. But I think with the positive margin, you'd probably want to look with an MRI sooner, wondering what everyone else thinks. Yeah,
and then first colonoscopy typically would be for someone like this patient would be a year from the surgery. Dr. Somavilla, would you change that approach?
I would probably do surveillance a little bit more closely in this patient.
When would you do the scope then?
Well, I would probably do excuse me, flexible sigmoidoscopy at 3 months.
There was one question in the chat box, and maybe I'll get Dr. Cantor's, not for a specific reason, but you are next. But what would you do if you would be the patient, they asked, in this case?
I've thought about that a lot. I am a very risk-averse person, which is a funny thing to say as a surgeon. Give me the bag. You can take my whole colon. Now my whole colon and rectum, I'll just go with an ileostomy. I still subscribe to a good TME dissection. I think in terms of nodal disease, et cetera, in a traditional TNT candidacy patient, that's what I would go. But then ultimately, even if I had a complete clinical response, I know myself, I would opt for surgery.
Okay, here's your answer then. Well, I think time is up, so we need to conclude here. I thank you all, the panelists, as well as the speakers. You guys did fantastic job, and I really appreciate your contribution tonight, as well as I thank everyone who attended this conference. And then next reminder is about our next webcast that will be on March 13, 2024. And we'll be talking about disparities in colorectal surgery. Have we shifted the needle? So we all looking forward to seeing you all at our next webcast on March 13. And have a good night from Cleveland. And thank you very much for attending again. Thank you.